name's Dr. Tracy Barr. I'm an emergency registrar at Royal Perth Hospital. This is 5 on Friday, and today's topic is headaches. Headaches are a very common presentation to any emergency department. They're actually the 5th most common complaint that we see in our ED. And whilst most of the times they can be quite a benign, self-limiting presentation, there's a small group of diagnoses that are sinister, critical, and what I call the not to be missed diagnoses. And that's what I'd like to focus on in the next few minutes. I'm going to run through some of the big, scary headaches that I would like people to have at the top of their list of differential diagnoses, talk about some of the pitfalls that people fall into, and finally just a couple of tips and tricks of the trade. Let's start with subarachnoid hemorrhages. This is probably the biggest one that everyone worries about, and rightly so. The definition of a subarachnoid hemorrhage is extravasation of blood into the subarachnoid space. It can be caused by either a traumatic cause, which we're not focusing on today, or a spontaneous cause. Spontaneous subarachnoid hemorrhages, 80% of the time, they're caused by a rupture of a cerebral berry aneurysm. An aneurysm is a weakening in the wall of the arteries, and it tends to be mostly in the anterior circulation of the circle of Willis. How do these people present? So the demographic tends to be the age between 40 to 60, although it can actually present in any age group, so it applies to any patient you see. The risk factors for a spontaneous rupture include things such as a previous history of a subarachnoid hemorrhage, a family history of a subarachnoid hemorrhage, high blood pressure, smoking, and the use of sympathomimetic drugs like cocaine and amphetamine, along with connective tissue disease. The classical presentation, so your patient will often say to you that they've had a sudden onset headache that feels like that thunderclap headache or a sledgehammer in the back of the head, and it's come on with maximum intensity within 10 minutes. If you hear that story, that needs to be triggering alarm bells in your head. Remember that 50% of these patients will also have had what's called a sentinel bleed or a warning bleed in the days or hours before. So sometimes patient might actually say that they've had a smaller headache before that. 2/3 of patient will not have had any other symptoms with it, although 1/3 of patient may have symptoms like a syncope, a seizure, some sort of focal neurology. But remember, they can just present with just a simple headache. So that's number one. The other group of headaches that you need to think about is the infectious causes. So meningitis, encephalitis, any intracranial infections. This group of patients tends to be your immunocompromised patients and patients who are at risk of any infection. They will often look unwell, they often have a fever, but they don't always have that classical triad of photophobia, meningism, and the headache together. So the Koenig's and the Brudzinski sign that you'll read about are great in theory, but in reality, they're not always that sensitive to pick up. The other group of patients that should always be someone that you need to worry about is your elderly patients. So anybody over the age of 50 who's never had a history of headaches is someone that you really need to be worrying about. There's a few diagnoses with these patients, apart from the ones I've mentioned. Giant cell arteritis. So they complain of pain around the temporal regions and scalp tenderness, and they need an urgent lab test, an ESR, or an erythrocyte sedimentation rate, and steroids. They could have a stroke, so look for focal neurology when you examine these patients, or they could also have a glaucoma, an acute close-angle glaucoma, and that tends to be missed, so ask about visual changes in there as well. Also remember patients on any medications, particularly anticoagulation. Old people, alcoholics on any anticoagulation can have a subdural bleed with minimal trauma. And the last group of patients to worry about is the pregnant patient. Don't forget preeclampsia in pregnant patients. This is a really important diagnosis not to be missed. So that's your group of worrying headaches. In terms of things that I think are really important, the good thing about headaches is while there's quite a range of headaches, most of it can be picked up on a good history and a good examination. So here's my number one tip. Apart from everything else you ask with your history, checking for all your red flags, the main question you need to ask every single patient with a headache is this: how is this headache different to any headache you've had in the past? That's it. Don't ask if this is the worst headache that they've ever had, because most patients will say that this is the worst headache they've ever had. How is this headache different to any headache you have ever had in the past? Remember that patients with migraines can have subarachnoids as well. Always do a really thorough focal neurological examination on a patient. Look for any focal weakness, any focal sensory loss, check visual acuity, and move the neck. You just need to check for a supple neck from a meningitic point of view. It doesn't need to be a formal Koenigs and Brudzinski's. And finally, analgesic response is not the best indicator. If someone's headache has disappeared with some painkillers, it doesn't mean that they haven't got a more insidious and a more sinister cause for their headache. So in summary, headaches are common. They can be caused by a lot of really benign, boring causes, but there's a few headaches that you really need to always run through and exclude whenever you see a patient with a headache. Ask that important question: how is this headache different to your previous headaches? And make sure you've done a really thorough neurological examination. That's it from me, and I hope you've enjoyed this podcast. Thank you.